Open. There's no reason to block. Yes. Okay, good.
Hi there.
Right.
I still don't have the webcam thinking.
Yeah.
Great.
But you are now as a presenter, Wietse. It looks like you can also start your webcam. Okay, everybody that has logged in already, we still have about another 10 minutes to start. So we are just waiting for everybody to log in. While you're waiting, maybe you can start to introduce yourselves on the chat box that you will find on your left. Just tell us which country you are logging in from and your organizational affiliation. And you will be able to see that from each other as well. So while we are waiting, my name is Yvonne Steep and I'm the moderator for today's webinar. You're not able to see me because we want to keep the connection as strong as possible. From our side, we can see that nearly 30 participants have already signed in, but we've still got 5 minutes to go. On the video screen there, you will see Marie-Adele Salam, who's going to be doing the second presentation today. I will introduce her later when everybody's on. And Wietse Tol, who will be doing only the presentation in English. So we're very excited because there are many people that have logged on to try and see the webinar. We've got people from over 45 countries that registered, and we've got nearly 200 people that want to listen to the webinar. Those that are not able to get in because it's full will get given a link and they can listen to the presentation live on YouTube. Afterwards, when we are finished, we will also put a link on our website. If people miss a part of it because they have to go early, always listen back to the recorded version, or they can listen to it on YouTube. I see we still have another 5 minutes to go, and the number of participants is increasing. I'm not able from my side to see where everyone is coming from, but the team will let me know. I can also maybe tell you while we are waiting that this is the second part of the series on gender-based violence. The first one we had on the 23rd of February, and that part focused on guidelines for integrating gender-based violence interventions in humanitarian settings, and it was presented by Jean Esquerdo. If you want to see that one, you're also able to find it back on our website. The link is actually there. And I can now also see where everybody is logging in from, and a really impressive list from all parts of the world. Also, while we're waiting, I can tell you that the next our presentation will be on the 27th of April at 11 a.m. UTC time for the English webinar and 1 p.m. for the Arabic one. It will be about MHPSS for persons with disability, and it will be illustrated by frontline examples from Gaza and Syria. You will also be able to see the link of the past webinar on the chat room. It's going to be posted for you there, so everybody will be able to see it. Okay, so it's just been posted for you. And this is going to stay there for a while, so you'll be able to go back to it. And it's quite nice to see this in relation to the webinar today, which is more practice orientated. We will be starting, and it's just giving a few minutes extra for people to still log in. And while we're waiting, well, you're able to see from each other where everyone has logged in from. Yes, I'm reading with you from Japan to Bianca. Bianca is just in Geneva, Boston, from Turkey, from Nigeria, from Malaysia, Lebanon, more from Turkey, Gaza. And I also see that participants are asking if they know each other, which is great. This is an ideal platform for you to also get to know each other better, and we really encourage you to stay in contact with each other. If you register as a member on the site, you will automatically be able to contact anybody else that is a member on the site as well. So at a later stage, you will use this same place to post your questions. And from there, you can also see if maybe someone is writing from somewhere that you want to follow up later. That would be great. You can also be part of a group after this webinar to continue the conversation on the website. So we will be able to, where you'll be able to carry on talking to each other, sharing experiences, giving tips. Someone from Yemen, someone from Oman. Okay, so we're at the time now that we could start, but we will give people just a few more minutes to register. Right, in exactly 4 minutes we will start. Carry on writing to each other. Let's see what you're doing. I'm noticing a few master's students from KwaZulu-Natal. Welcome to you too. If you want to post anything else about your experience, please feel welcome. to do so. So our webinar series is going to run throughout the year. It will be about, we will try and have one webinar a month. And there is a WhatsApp number that you can also enroll in to be alerted for the following webinars that are coming up. So you will see that number appear on your screen in case you're not already on, but many of you will be on already. And the people that log in on YouTube, and there are already 15 on YouTube, you will also be able to chat on the YouTube channel. This particular webinar that we're on now will be recorded as well, and you can listen back to that one too. The ones that have logged into YouTube, can you post your questions there, and they will be reposted in the chat room so that our presenters also receive those questions, and the link will be made available. And thank you for your patience, our presenters. And for the ones that have logged in since I started, you're very welcome. Okay, I'm going to repeat what I said earlier on, and as part of the introduction, so that we can get going with our webinar. My name is Yvonne Sleep. I'm moderating today's webinar, and on the video you can see our two presenters. You cannot see me because we're trying to keep the connection strong. Just to repeat for those that didn't hear, we are running these webinars monthly on different topics, and you can get alerted and also see on the website when what the program is and which ones you would like to watch. They will all be related to mental health and psychosocial support. This is the second series of the second webinar on gender-based violence. The first one was a month ago, and the link for that one that was recorded you can find on the website. You don't have to be a member to get it, but you are able to, you're very welcome to join the site as well in becoming a member, where you'll be able to also join groups and take part in other discussions. So just again to encourage the people that that are still logging in now to please introduce yourselves on the chat site. Write your name, where you're from, and what your organization you're affiliated to, so that you can get to know each other. Everybody will be able to see what you post. So this is also where you will write your questions. So how the webinar works is that each presenter will be given about 15 minutes to do their presentation, one directly after the other. This is followed by about 20 minutes question time and answer time. The questions you post in the chat section will be collated and given back to me to ask the presenters. The answers will be to the point, directly related to the presentation. At the end of the presentation, we will put up a link for you to evaluate the webinar. This will only take about 2 minutes to answer, and we request that you do it immediately after the webinar, as it's valuable feedback for us to continue providing you with high quality webinars. For this first presentation today, we have two presenters. This is the English one. Wietse Tol, who's a psychologist and a public mental health specialist working for the Department of Mental Health of Johns Hopkins Bloomberg School of Public Health. He is also the program director of the Peter Alderman Foundation. Wietse will present on the Nguvu project that was done with Congolese refugee women in Tanzania to reduce intimate partner violence. He will only present in English, and today he's connecting from Uganda. And you will be the first presenter, but I will first introduce Marie-Adele Salim, who is an expert in mental health and from today, with numerous organizations in this area developing and evaluating programs. She's currently a consultant trainer and an MHPSS advisor for ABAD, which focuses on strengthening women in the MENA region. Will be presenting the Protection Shelter for Women and Girl Survivors of GBV project and how MHPSS services are integrated into the overall protection and case management system. So these are all very practical ways in which the guidelines are applied. She will be doing a presentation in English during this session, and 2 hours from now she will repeat this presentation in Arabic. Welcome, Marie-Adele. Wietse, I would now like to invite you to start your presentation, please.
Thank you. Thank you very much. I'm very grateful and honored to be able to present our work in Tanzania on this forum. It's really nice to see so many participants from so many countries in this space. Can we have my presentation up?
Sorry about that. It's going to start in a second.
It's just a bit. It is helpful to have the presentation up for me.
Absolutely. While we are waiting, I was curious because you today you are speaking to us from Uganda. A few days ago it was from Denmark. You are based in the States. You're a mover.
Yeah, unfortunately, I'm based in Uganda, but I'm actually talking to you from a public library in Denmark. Traveling.
Okay. Thank you for the clarification.
That's why the connection is pretty good.
Ah, we're lucky. And your presentation is up. Please start.
Great. Thanks a lot. Yeah, so I'd like to present on a project called Nguvu. And Nguvu means strength in Kiswahili, a language spoken widely in Eastern Africa, but especially in Tanzania and in Kenya, and also in the refugee camp that I'd like to present takes place. And the project is an effort to integrate two goals. One goal is to reduce intimate partner violence, and at the same time, we try to reduce psychological distress in the same intervention. And I would like to present the reasons why we are doing that, the background for that goal. But first, the project is a partnership between several academic partners and several humanitarian partners. We're very honored to work with the International Rescue Committee, as well as the UN Refugee Agency as humanitarian partners, and also with Muhimbili University for Health and Allied Sciences, which is a university in Dar es Salaam, and the university where I work in Baltimore in the United States, Johns Hopkins. We represent a diverse team, and we are funded by a program called Research for Health and Humanitarian Crises, which is a program funded by the Wellcome Trust and DFID, which aims to strengthen collaboration between universities and humanitarian partners, and strengthen knowledge on health interventions in humanitarian settings. Let me start with saying a bit more about the location where we work. We work in Nyarugusu refugee camp, which is a camp in northwestern Tanzania in the province of Kigoma. Around 100,000 people living there across 12 zones. When we started the project, which is actually already a few years ago, there were mainly Congolese refugees because Burundian refugees had been repatriated. But in the time that the project started, large numbers of Burundian refugees came in because of political instability there. And we, nonetheless, decided to continue our program with Congolese refugees for reasons that I'll touch on later. We started the project with more open-ended research, more open-ended participatory qualitative research that consisted of 40 interviews in which we asked staff of humanitarian agencies that already are engaged in working with women who have experienced GBV to list the key concerns that they see, and to also list the key psychosocial and mental health concerns that they see in women who've survived gender-based violence. We also conducted 15 key informant interviews with more experts to understand better what those kinds of mental health problems and priorities look like. We conducted a mapping of gender-based violence activities work, and we conducted a desk review. In other words, we did a wide literature search to understand which knowledge was already available in libraries and on the internet in program documents, to make sure that we were not duplicating any efforts or were collecting information that was already known. So we found out that the three mental health problems that were prioritized most by the people we spoke with were stress, or msongo wa mawazo, sadness, or huzuni, and fear. So we decided to develop a project that was focused on psychological distress to target the key informant interview is expressed by there, of course, being unhappiness, but also women excluding themselves. Socially, sadness was recognized by crying, silence, and also aggression, and fear was recognized more by worry, and also worry and fear when women saw their husbands. Before I get to our intervention design, I also want to say that I realize that this is a webinar, but we found this violence with the Congolese population in this camp was intimate partner violence. I know that the media has focused much more on sexual violence as part of the Congo conflict perpetrated by armed forces, but we found that the most common form of gender-based violence, as is common elsewhere in the world, was intimate partner violence, so violence perpetrated by husbands against their spouses, or partners if they were not married. We did the formative research, and we were interested in developing an intervention that focused on psychological distress as well as intimate partner violence. And looked at the literature. It's very well known that intimate partner violence is a major risk factor for psychological distress, or for depression more narrowly. That's more commonly conceptualized in studies as depression. There's a 2 to 3-fold higher risk in women who've experienced or are experiencing IPV to develop depression. What is less well known, but I think absolutely critical, is that psychological distress in turn makes it more likely that you experience future violence. And I think this is quite process, but it also makes sense, I think. As part of depression, it's commonly found that people's thinking styles change. People might be more at risk to themselves being to blame for the misery and adversity they experience in their lives, or they might feel that they are bad people, that they're not in charge of relationships that they have, that they're overall without agency and control, that thinking styles are present. Depression actually doubles your risk to experience intimate partner violence. This is more recent. These are findings from more recent studies, but I think that's absolutely critical to keep in mind. It means that if you want to break this vicious cycle, you will have to develop an integrated program. If you only target IPV, which I think is common in humanitarian agencies, because humanitarian interventions are often implemented across sectors, so they're quite separated from each other. So in the might be action on intimate partner violence, but if there are high levels of psychological distress, then the risks for IPV remain. And also from a health sector point of view, it's possible to treat depression. There are evidence-based interventions available that can be implemented also in very difficult humanitarian settings. But if intimate partner violence remains very common in a refugee camp, then women remain at risk for developing depression again or anew. So we feel that it's really important to try and develop interventions that target this cycle of misery at two sides. So we think it's important that we start developing interventions that both look at IPV as well as at mental health at the same time. So an integrated intervention can start breaking this cycle. When we searched the literature after our formative research, we were lucky to find an intervention that was already evaluated in the Eastern Democratic Republic of the Congo, cognitive processing therapy. This was evaluated through a randomized control opportunity. We also found that there are strong it evaluated in its format. We want that in a so from an IPV perspective, we are with work experiencing a common feedback that is that aren't you also working to be and so motto, primary prevention is an absolutely essential activity, but it's not what this specific intervention is focused on, because there was already a strong primary prevention set of projects going on in Nyarugusu. The IRC is the protection partner for UNHCR and the government in Tanzania, and they already have a range of programs in place. So I want to emphasize that the intervention that I'm presenting should only be implemented in an area where there are already important primary prevention activities for IPV ongoing. The effect of our aim is to reduce distress because we know that that IPV is a strong causal factor for psychological distress. We're really trying to hit two birds with one stone. So the intervention has 8 sessions. The middle part is made up by the group cognitive processing, 6 sessions, and that is really groups of around 12 women discussing the kinds of things that they think as part of their experiences of intimate partner violence. And this group therapy model was developed specifically for women who experience gender-based violence every week through sessions with a specific theme, and to try and be critical about the things that you're telling yourself about the intimate partner violence. For example, thinking about who is to blame. Is it because you feel that you are a bad woman, because you are yourself to blame? Self-esteem, issues of control. Through quite simple means, the women in the group start to develop skills in looking at how they think and try to break through negative thinking styles that make it more likely that they will remain in difficult. Of course, fully recognizing that it's not their thinking styles that put them at risk in the first place, but that is GBV that's perpetrated against them. That developed building on the literature. The situation of IPV, for discussing the options for safety in the camp, for safety planning for the women individually. In the last session, the women come back to those safety plans, but now after having gone through the group support and the cognitive processing therapy to see if there are any changes to the safety plan that they can make based upon the group process that they have gone through. All of the intervention is implemented by Congolese refugee women who are working with refugee incentive staff, by 2 excellent consultants, Marianne Tankink and Amy Jocelyn, in both those interventions components. Here you can see the group of women that has been trained, as well as the trainers in the picture. Pilot and we're about to start a randomized controlled trial. You see our revised from women's group, one of the zones, conducted screening. Everyone went through the 8 intervention sessions, and then we did qualitative active interviews with women who stayed sessions and material that in this, that's one of the practical things that we are doing. Is we're not forming separate groups, but we are running through women's groups that are already existing in the camps, and those were started by humanitarian agencies to strengthen empowerment for women, generally through kind of micro livelihood skills, so making soap or other kinds of joint activities. So we approach the leadership of those groups and present our intervention, and then ask if we may speak with the women's groups to explain what we are doing and to ask which women might benefit from the intervention. We screened 102 people and found that 61 were eligible. In the end, 60 of the women were interested in joining. And what we found is that there are very high levels of mental health problems in that group of women. As you can see on a scale from 0 to 3, on average, women scored 2.3 on symptoms of anxiety, symptoms of depression, and symptoms of post-traumatic stress. To find that most of the intimate partner violence that women experienced was a combination of sexual and psychological and physical intimate partner violence. That was by far the most common form of women. In terms of frequency, on a scale from 0 to 2, we found that sexual violence was the most commonly reported in the last year, and less so psychological, and also less so physical violence. And, in short, what we learned from the pilot studies that we had very high levels of mental health problems in this particular sample, higher than what we would expect based upon use of the same scales in other populations. Experienced different types of intimate partner violence, and that we didn't expect that we faced were issues related to age. We found that it was important to separate young women from older women. They found it quite difficult and uncomfortable to talk to each other about their experiences. Also, as I said, we worked through existing women's groups networks, but what we did in the pilot is that we split up women from the same women's group into several Nguvu groups, and the women told us that it would be more helpful to actually build off completely off the existing networks. Challenges, we found that, of course, it's hard to do this when there are competing activities going on at the camp, for example, food distribution days, or other types of activities by humanitarian agencies. So just concretely very important to plan the sessions very well. Yeah, and as I said, I think in a camp like this, there's always a lot going on. The influx of Burundian refugees really changed the humanitarian environment, as well as the willingness of women to work with us or with other humanitarian initiatives. We have to continue to be very flexible and adaptive to the changing circumstances. And also, cultural sensitivity was an important point for us. And we continue to look for areas where we can make sure that it's with people's experiences there. But so far, we haven't come across any really large issues that we needed to adapt. The study design I can skip over. I really wanted to speak mainly about our experiences in developing and in piloting this new intervention. Thank you.
Thank you, Wietse. Some very interesting results that are important for our future interventions have come out of your presentation. We will discuss it some more from the questions later on, but first I would like to invite Marie-Adele to do her presentation as soon as the screen comes on. Thank you, Marie-Adele. You can go ahead. Marie, we can't hear you. Marie, can you hear me? Nod your head if you can hear me. Okay, now we can hear you too.
Just for that. So I was thanking Wietse and Yvonne for the presentation and Yvonne for the facilitation. I would like to start by thanking everyone for being here today, and I will read the sentence written by Moni El-Qayyim, who's a systemic psychotherapist, when he said that everything happens in the intersection of various systems that are in constant interaction between and with each other. The webinar today is a proof of that. We're gathering to discuss GBV and mental health by the distances. I'd like to talk about the gender-based violence, the roots of the gender-based violence as we perceive it here at Abad. So, as Yvonne said, I'm the mental health and psychosocial advisor for Abad, which is a Lebanese organization working on the problematic of GBV and gender-based violence from a perspective that is more engaging men rather than seeing only women as victim and men as perpetrator. We try to see the problematic of GBV from a systemic point of view. So in this slide you can see a bit, excuse me, it's in Arabic, but I will read it in English. So we try to put levels for the roots of GBV, of gender-based violence, to try and understand these roots in order to better plan our strategy of intervention to change in the context where we work in. So the first level is the context of the region, the different norms and traditions, the laws, the religion, and the education, the media, and its impact on the privileges that are given to men or women. From this first level, we go to the second level, affected by the context, that is the implicit dynamics that are leading a woman to perceive herself as a woman, and what are the criteria defining her as a woman, and how she can choose or not a partner, and vice versa. So how a man is perceiving himself and how he's choosing his partner as well. We go to the third level, which is the more explicit level, where we see in the interaction between man and woman and the intersection of their interaction, we can see the manifestation of the violent dynamics. So it's just briefly a way of explaining to the people we work with, as well as in our advocacy campaigns, that violence is not just an event that is happening because a woman is a victim or a man is a perpetrator. It's a much more complex dynamic that we should all work on and understand differently. In a nutshell as well, the different strategies implemented by Abad to arrive to a sustainable change, or to ensure a sustainable change on the community level, on the family level, and on the individual level. We work a lot on the context through advocacy campaigns, through working with decision makers, politicians, the juridical decision makers, so judges, the internal security forces who are usually involved in violence happening against women. We work directly on enhancing the qualities of services that are presented to survivors. So whether it's case management to support GBV survivors, or mental health or legal services presented as well. And we make sure that the beneficiaries that are at least benefiting from the services we provide at Abad are empowered to become advocates for change in their own communities as well. So this is, in a nutshell, the strategy of change that Abad follows. In our presentation today, I will be talking briefly about the services that we provide where mental health and GBV are intersecting. So we have a center for men with aggressive behaviors. In the center, men who wish to work on their aggressive behavior can receive individual psychotherapy as well as couple and family therapy. in order to work with them on understanding the root causes of violence, on understanding that violence is an unhealthy way of communication of what they are feeling or thinking, and on the gender roles that they are also trapped in, as well as women in our societies. So I can say that this center is a pioneer project in the area, because for the first time, men who are feeling the need to be supported and to change their behavior are finding the space, safe and confidential space to do so. Another project, sorry. Collaboration with, we have 8 different centers in Lebanon where women and girls at risk of GBV can receive mental health, psychosocial, and case management support. And when women they are referred to the safe shelters. Safe shelters that I will be presenting today called Al-Dar, or house, safe house, if I can say. We have 3 different Lebanon, in the north, in the Bekaa, and in the south. And in these shelters, women who are at risk and danger of being threatened, like with extreme danger, usually receive the safe sheltering, and as well as specialized multidisciplinary services that are provided for them until we find a solution for their situation based on their priorities and wishes and rights, of course. So we follow a survival approach. I will be explaining briefly the strategy of mental health and psychosocial intervention that is implemented. I say as well that this strategy was developed following of capitalization of experiences and lessons learned, because across the region there was no references, if I can say, to guide us on what's wrong and do's and don'ts, if I can say, to support women and girls who are asking for this protection in our shelters. So following 3 years of capitalizations of lesson learned, we developed a strategy based on the assessment of needs and based on the input that survivors who benefited from the services are giving us. So as you can see, the strategy is divided into 5 steps. I'm sorry, I think I should take something for my voice. So the strategy is divided into 5 steps. The welcoming, drafting the action plan, the case management action plan, and the MHPSS action plan, the implementation of these plans, and then the closure and planning of an active role for women, as I said, because we empower beneficiaries to have a role of advocates for change. And finally, the evaluation and the integration of the beneficiaries' feedback into the overall planning for the years to come. Our main focus is basically on, because I can see we still have only 5 minutes left, so I would focus on the step 3, which is directly the MHPSS plan that is being implemented. And I should say that in this plan, we usually focus on 3 main levels, which is the intrapersonal, so the relation of the person with herself, the interpersonal, the relation of the survivor with others, whether colleagues, family members, staff members, or even others, meaning the system. And I will explain this point in a few seconds. Then the third level is more acquiring self-help and self-protection skills that she can use on a later stage when she's out of the protection shelter. To give further practical examples about these levels, so on the level of intrapersonal level, the level of relation of the survivor with herself, we work a lot on her identity, the way she perceives herself, and on the emotional self-awareness. So she's able to better use her mindfulness to understand what she's feeling now, whether fear or anger or whatever other feelings she's having, and to link those specific emotions to specific situations that are coming from the past, from the present, in order to better have control on her future. On the interpersonal level, we work on mainly on the concept of trust, because women who were abused, it's not only their body that was abused, it's also the relation to the others. So the concept of trust, if I can say, is also abused. So they have difficulty in trusting others and in building healthy relationship with others, especially also with systems. So even if at the protection shelter, the system is there to protect them, some women have difficulties in trusting and accepting the system, even if it's a system of protection. So working on this perception, on her perception of this pattern, understanding it and breaking it in order to build healthy relationships is important for her, for a sustainable change, if I can say, for the future. I will go directly to the self-help mechanism. So we work a lot on life skills and on her acquiring skills that can help her in the future to take control on her life, and to continue in a healthy way of self-protection and of self-accomplishment. The last steps, as I was saying, were more to give her the space to develop social initiatives where she experiences all the skills that she acquired during her stay at the shelter in a safe environment before she's alone responsible of her own life when she's out of the shelter. And the last stage, as I was saying, is the evaluation. We take into account the feedback of the beneficiaries in order to best tailor the intervention to their needs and priorities. So that's it in a nutshell. My time is up. Thank you. John?
Are you able to hear me? Okay. No, so sorry, I just am thanking both the facilitators. Sorry about the technical problem here for a second. There's an overlap between the two programs, and we saw, yes, but also some differences with the Wietse side breaking the cycles of depression, and from Marie-Adele's side, the effects of the family and the mindfulness about the feelings they're experiencing, the activity in the field. We have had one question come in already from someone who could not log in. But Wietse, I'll give this to you first. Erin Joyce wanted to know what recommendations you have for practitioners to adapt the interventions to child survivors of GBV. Do you have an answer on that?
Yeah, we discussed that question briefly before we got started. And I think that's quite a difficult question because it is quite broad. But if I think about that more specifically for our case, what we are trying to do is combine a psychological support intervention with an intervention that's more specifically aimed at increasing safety. And for children, especially younger children, I think it would be really important to include the support system around the child in an intervention like that. And I think that the system that we have gone through is a system of doing an assessment in the local context to see what kind of resources are already available and to see what kind of intervention could be added to both what the humanitarian agencies are doing, but also what survivors of GBV themselves are doing. And I think it's very hard to answer a broad question like that when our approach really has been to look in each situation specifically what the needs are.
Yes. Yes.
So we would probably choose a very different approach.
Yeah. Okay. Thank you, Wietse. Marie-Adele, I don't know if you want to add to that briefly.
Sorry, Yvonne, I can't.
Okay, I'm not getting. Okay. Can you hear me now? I will ask another question from you. There is a question from Zara, who is a protection officer for UNHCR in Nairobi. You can also read it on the screen, Marie. And she wants to know how you manage to convince men to come. Okay. Then read the question, please. Thank you for telling me. It is the question from UNHCR.
Yes. So Zara is asking, how do you manage to convince men to come forward to attend your sessions? So as I was saying, we have a lot of advocacy and media campaigns to raise awareness regarding the issue. And I think most of men, when they hear that, we're not accusing them or judging them. We're just saying that they are also victims of the context. I mean, they also have a lot of norms and traditions to stick to in order to show their manhood. So this helps a lot of men to already come and ask for help. And during the sessions as well, when they are self-referred, let's say, they are here to also see our approach and how does it work. And it's very important to highlight during the sessions that we're not judging them. There is a difference between judging or accusing and holding a person accountable. So everyone is accountable for his own behavior, let's say. However, with the help of the psychotherapist, they can reach a point where they can express with words what they are already expressing through their violent behavior. And a lot of men are really finding this approach effective, and they are also asking for couple therapy in order to make sure that what they changed in themselves will be also changed at the family level, and how others are perceiving them in order to ensure a sustainable change.
Yeah, very important. That's where the cycles of violence have to be broken. Wietse, you mentioned that you are competing with other humanitarian activities. What was the level of intrinsic motivation for survivors to participate in the full intervention?
So I think that motivation started to spike more in the second session and third session, when women really started to understand what the intervention can do for them, what it can improve for them. I think this is a setting where violence against women is really normalized and is expected by women almost. and at the same time, women are not supposed to complain about things that happen in the household. You're supposed to suffer in silence and not bring out the dirty laundry, as it were. So to discuss intimate partner violence with other women is something that is not necessarily seen as the thing that you normally do, but as soon as women start experiencing how supportive and how powerful that can be, and that that violence is not normal, and that it's not, so that's when those groups become very tight, and women want to come back.
And that is the power of the group discussions, in addition to the individual approach. Marie, there is another question for you. Do you follow women after they leave the shelter to see how they are able to integrate in the community, especially in the context of culture and what type of support? I did hear you say that you even give them a role in the community, but let's hear a bit more.
I can't hear you well, Ivan.
The question is also on the chat site for you. It's in.
Okay, so I'll just read it.
Okay.
Okay. So the next question was about if we follow women after they go out of the shelter, see how they are able to integrate back in the community, especially in the context of the culture, and what type of support do we provide. Yes, we do actually. So as I said, we have different projects running where GBV and mental health are intersecting, and in the women and girls safe spaces that are existing across Lebanon in 8 different areas, and these are open centers. Women who benefited from the shelter services and who are now empowered enough and who have more safer conditions to get out of the shelter are being followed by the case managers and the psychotherapists working in the women and girls safe spaces and the open centers. So of course it's up to them to decide whether they want to continue this follow-up or not. Most of them wish to do so, and some of them as well ask for couple therapy and family therapy as well, and whether in the women and girls safe spaces or at the men's center.
Yes. Yeah, that makes total sense in relation to what you explained before as well. Wietse, you mentioned that it's difficult to compete. No, I've asked you that. How do the women change their behavior towards after the training has been done on how the causes of violence are diminished?
Mm-hmm. The short answer is we don't know yet, because we haven't done an evaluation after the implementation. We've just piloted the intervention to make sure that it's implemented as we were planning. So we are measuring safety behaviors after the intervention, so I can tell you more about that later. What we have seen so far is, I think, mainly the changes from the refugee incentive workers that have facilitated the sessions, the Nguvu facilitators. If we compare our conversations with them, with the conversations we're having with, for example, the research interviewers, we can really see a difference of light and day, strengthening, I think, our impressions that this is a really promising approach. And what I found quite powerful in the explanations of the facilitators is, well, first of all, that they almost get addicted to kind of the critical questions they can ask themselves, and what they call the thinking questions and challenging themselves questions, that they stop taking violence as a normal activity that should just be accepted, but that they see that as something that they may want to do something about. Of course, within the very real limitations that the women in that refugee camp face.
Yes, so maybe you've got some experience about that as well, Marie. How do you motivate men to change their behavior in your intervention?
I should say that we have two different profiles of men with aggressive behaviors. So we have people who just use violence in a situational, we call it like situational violence, if I can, I can say it this way. And the other profile is more called like the terrorist violence to describe it. So it's either men who occasionally use violence because of lack of control on their impulsivity and because of stress and all the different factors affecting their ability to control themselves, contextually, I mean. And the other profile is more, men who have the violence integrated and rooted in their way of thinking and of behaving with others. And the situational violence, men usually, we don't have a lot of difficulties in engaging men in the process of the therapy of support, but also on the later stage in giving them an active role in their own societies. They are either self-referred, as I said earlier, or they are referred by other NGOs because they express the needs. In that case, the therapy is helping. However, in the second case, the process is more complex, and sometimes they are referred by the tribunal because their situation at home, the domestic violence, was raised to the judge, and the judge decided that the person needs rehabilitation, as they call it in the juridical vocabulary here. So in that case, the therapy is not very effective because the man didn't ask himself for therapy or support. He was obliged to.
Yes. Yes, it's a complex situation. Wietse, also talking about complexity in emergency response, how does the local community, there's one question, for instance, with the influx of Burundians, how do the Congolese refugees respond? They're very stressed about their arrival, and does that also affect the intimate partner violence?
I think so. We don't have hard figures about that. The registration of GBV incidents relies on reporting by women themselves. There's no community-based tracking of GBV incidents, so I'm not sure how easy it is to answer that question, but I would say yes. I think an additional major stressor for the Congolese refugee women has been that the resettlement process seems to be under a lot of stress because of what's happened in the United States. And I really learning. There's so much connecting. For us, what we really look at is the small part of individual women's mental health and their ability to stay safe. But we see that there's so much going on in the context of women, and we see ourselves as just a small cog in a larger needed package of interventions that also addresses GBV at the community level, that engages with men. It's not what we do, but we specifically chose to work with agencies that have those kinds of interventions in place, and we made sure to map those interventions before we started developing ours.
Yeah. And I mean, it is all the bits that come together that make the big difference in the end. So if we look at the other spectrum, Marie, is there any work being done to help women working as domestic servants in Lebanon?
Unfortunately, it's a human rights violation. A lot of women are being abused or are in very difficult situations because of the laws regarding the domestic workers in Lebanon. At Abad, we don't have advocacies or interventions directly to tackle this problematic. However, at the shelter, we receive victims victims who were abused or harassed or who were not giving their rights, if I can say, and who were in great danger because of the laws that are not protecting migrant workers in Lebanon.
Yes, it was an interesting question to see who may fall through the net, and really the interventions have to go everywhere. There's another question for Wietse. That it's from a clinical psychologist who's speaking about the kind of intervention you set up and that it can lead to psychological distress as well. So the question is, how effective is the brief therapy sessions, and is there any follow-up after the 8th session, after you've stopped the program, with the survivor and or the partner?
Right. So we took an intervention that had already been evaluated in the Eastern DRC, and where it showed to be very effective. That there was a rigorous evaluation study using randomized controlled trial design, and that showed that the 12-session version very strongly, effectively reduced depression, anxiety, PTSD complaints, and also reduced impairment in daily functioning for women. What we are doing is taking that intervention into the Congolese refugee context and shortening it from 12 to 6 sessions. And that had already been done by an Australian psychologist that we worked with in the development of our package. I don't know of so much research that tests the 6-session package versus the 12-session package, but there is quite a bit of research that looks at similar types of group psychotherapy in that amount of sessions, and generally shows that it can be effective. So we're expecting that this will also work.
Yes, there's indeed quite a lot of programs that are doing that now, the prime programs as well, that are being done in Africa, and it does sound promising, and really how much resources. We also have a question that can be maybe it can be answered by you, Marie. To what level, or do you see a change in the resilience of women if they have undergone psychological intervention? This is asked from someone in KwaZulu-Natal.
I should say that women are very resilient, whether I'm talking about women at the shelter or women who just come to receive services in the WGSS. They are already very resilient, otherwise they will not be able to survive the difficult events they go through because of the problematic of GBV. We do observe a change in their coping mechanisms, because usually their coping mechanisms are mainly negative, if I can say. They tend more to deal with their difficult situations by isolating themselves or by blaming themselves, or they develop a learned helplessness. However, after receiving the support, and it's again MHPSS support, so it's not only psychotherapy, it's also group support and different activities.
Sorry. Okay, Wietse, I'm not sure if you can hear me, but maybe you have got something to add on to what Marie-Adele was saying, because we seem to have lost her connection. In terms of the resilience. We are just waiting to see if we can get Marie back. But in case you can add on to what she was saying. But there was also a question around how you are managing sustainability of such a big intervention that seems to take quite a bit of money. Are you working with other partners as well?
Is that a question for me, Yvonne? I missed a part of that.
Yes, yes. Okay, the question is in relation to sustainability with the PSS interventions after the study. How will you manage to keep it going? And are you working with other partners?
Yeah, so one of the goals of the work that we are doing is specifically to develop an intervention that can be sustainable. So rather than look at longer group psychotherapies that have been evaluated positively, we wanted to look at a shortened psychological intervention and combine that with another issue. And on purpose, we are working as a group of universities and humanitarian organizations to make sure that the work we do together doesn't end up in an academic drawer somewhere, but that we can engage with the humanitarian partners to see how we can make sure that the interventions keep on being implemented. And what's nice about the R2HC funding is that there is specific funding to work on that. So after we get in results, I think first we want to know if the intervention is effective, and if it is, we of course would like to see how we can implement and disseminate it, and we have specific funding and time to look at that. That's been, we don't know yet, but we definitely designed intervention to make it as easy as possible to sustain it.
That's very encouraging to hear. I think that's often a dilemma we face when we come in with a study, even if it's participatory research. How does it continue? Thank you very much, both of you. You've really stimulated us, and we know that the people that are signing in on these programs often also have ideas of how things can be done, and we would like to encourage the participants to continue to share ideas. I just want to remind the participants that there is going to be a short evaluation. We would really like you to fill it in directly after the webinar is completed. Just press on the evaluation link. It's a few short questions, and then we can get some feedback. If the feedback we get, we will use to keep our sessions going. But in combination with the first webinar, which was the guidelines, and seeing how this is being rolled out, as well as the importance of linking evidence-based to our interventions so that we can learn from them. And we heard very nice examples how that gives us new insight in approaching our interventions. Thank you very much again to both of you for a very informative session.
Thank you. Thanks also to the participants for the great questions, and thank you, Yvonne, for moderating.
Thank you. I just want to remind everybody that in an hour's time, those that speak Arabic will be able to hear Marie's presentation in Arabic, and she will have a bit longer time to answer questions. So carry on formulating your questions, and you can put them on the site for Marie's question. The next session will be moderated by Zainab Hijazi, and it will start in exactly 1 hour's time. Thank you very much, everyone. Also to the people who are in the back room making this possible.